Now we've got the backdrop for our body's endocannabinoid system, a self-healing, self-regulatory system, this concept of network pharmacology, complex interactions, and hopefully letting go of some of the need to understand all that complexity in a reductionistic way, but feeling a little more comfortable zooming out and understanding that the future of medicine and the past may be these complex botanical medicines used appropriately. And I really believe and am seeing now that cannabis is the gateway. Cannabis is leading medicine back to greater comfort with a botanical treatment, greater comfort with multi-constituent treatment, and complexity, levels of complexity that we don't fully understand yet are comfortable enough with because of the safety profile to use in our patients. So let's dig into cannabis, or actually specifically cannabinoid pharmacology. The following lecture will address the terpenes. And so here we have the flower, the compound flower of Cannabis sativa. And if we zoom in a little bit more, we see the trichomes. These are resin glands present on the little flowering structures, and this is where all the magic happens. These are factories of dozens, hundreds of compounds that have physiologic activity. And so just zooming in, the things that we're focused most on would be the THC and the CBD. And of course, as Dr. Mishulam pointed out this morning, very low levels of THC and CBD are found in the raw cannabis flower. It's actually the THCA and the CBDA, the acidic forms, and you can see that little carboxylic acid moiety on the molecules there. And those were considered the inactive forms of these compounds for a long time, and now they're starting to gain some recognition. But of course, raw or very slightly heated preparations of cannabis have been used in medicine for a very long time. So we're going to dig into THC and CBD first, and then we'll take a tour of some of the other cannabinoid compounds. So THC is a partial agonist at the CB1 and CB2 receptor, much like anandamide. THC very closely mimics the activity of our endocannabinoids, and probably the biggest difference is that when someone is exposed to THC, this exogenous phytocannabinoid, they end up with a global cannabinoid effect, right? It's going to be distributed into all the tissues and affect them systemically. I'm just going to try to get this a little closer. Compared to when our bodies make anandamide, it's done in a very specific manner and it has very short-term activity. But the effects of THC, analgesic, antipruritic, agonist at CB1, bronchodilatory, neuroprotective, anti-inflammatory, anti-emetic, and then of course the psychoactive, but that's just to name a few. Really anything that CB1 and CB2 can do, THC can do. Now, that's probably the most clinically relevant function of THC, but a lot of people aren't aware that THC is extraordinarily active or promiscuous, if you would say, at other targets. We don't know how relevant some of these targets are, but THC activates two other G protein couple receptors that are at least peripherally involved in the endocannabinoid system. That's 18 and 55, PPAR gamma, TRPA1, TRPV2, TRPV3, and TRPV4. So notice the absence of TRPV1, which is the capsaicin receptor, but THC is active at other receptors in this vanilloid system. And then THC has some receptor inhibition activity as well. Again, these show up mostly in vitro work. We don't know how clinically relevant they are, but they probably, some of them are in some situations. THC also has a lot of effects actually enhancing or decreasing the activity of various enzymes throughout the body. Again, not really sure how clinically relevant, but I like to point out what we don't know because I think that helps us prevent ourselves from assuming we know everything. There's a lot going on with just THC. THC is also inhibiting or enhancing transporters of various well, you can see there, adenosine, dopamine, noradrenaline, serotonin. So the transport of these from the synapse back into the cell can be enhanced or inhibited by THC. So a lot going on there with THC, although it's probably mostly this partial agonist effect at CB1 and CB2. Now CBD is quite different. It has a lot of overlap with THC in its clinical effects. Both can help with pain, both can help with anxiety, with inflammation, and so forth. And it's interesting that CBD does not directly act upon the main targets of THC, the CB1 and CB2 receptors. It has very low affinity for those receptors, and in fact, it acts as a non-competitive inverse agonist. So a competitive agonist or a full agonist is something that would just completely block the activity of either THC or the endocannabinoids at this receptor. We have a molecule that does this called rimonabant, very useful in research. It was actually approved as a drug given to people in Europe. They experienced severe side effects, including dysphoria, depression, and suicide, and so it was pulled. The goal with rimonabant as a therapeutic agent was to limit the munchies and actually be an anti-obesity drug, but it limited a lot more than the munchies. CBD is very different from that. It doesn't block the CB1 receptor, as you can, if you can see in the bottom image there. It's interacting at an allosteric site, so the anandamide, the 2-AG, the THC could still bind to the receptor, but the signal that comes out of this receptor is turned down. So CBD is basically turning down the volume of the activity of these CB1 agonists, and likely CB2 as well, even though that's not super clear yet. But that's not exactly how that's not the only way that CBD is working. And I think a lot of the benefits that we attribute to CBD are not based on this negative allosteric modulation of CB1 and CB2. They're based on these other targets, especially the 5-HT1A serotonin receptor, which is likely the mechanism of CBD's anti-nausea properties and probably some of its mood-boosting properties, as well as some of its ability to protect the central nervous system after an insult, because interacting with that receptor can improve vascular supply to damaged areas. The TRPV1 through TRPV4, and that includes the TRPV1 capsaicin receptor, which is a great target for pain, inflammation, and some psychiatric illness. PPAR gamma has been mentioned several times today. Also the glycine receptor, which has implications for pain. And then CBD antagonizes a variety of receptors. We don't have to go through them all. And it inhibits the transport or reuptake of various neurotransmitters. And if you notice the bottom one there, anandamide, which is quite important. So while CBD is turning down the volume at CB1 and maybe CB2 as well, it's also enhancing the activity of anandamide by keeping it around in the synapse, by inhibiting its reuptake, and also weakly inhibiting Pha, which is the enzyme that breaks down anandamide. So actually two different mechanisms of increasing anandamide activity, which would then enhance CB1 signaling. So CBD is kind of working on CB1 in two different directions here. And then CBD also has activity in the mitochondria, which is interesting. We didn't have time to mention it this morning, but the mitochondria have cannabinoid receptors as well. And so much of medicine is now starting to look at mitochondrial function as a major player in neurologic illness and chronic disease. And I think the cannabinoid system has some things to offer us there. But to tie this all up with CBD, we see these antispasmodic and anxiolytic and antidepressant and so forth, neuroprotective effects, just a basic summary slide. In my experience, CBD works the best in combination with THC. This is where it really shines. As a standalone agent, a single molecule pharmaceutical, CBD absolutely has some power, but really in the context of some of the other aspects of the plant, in particular THC, CBD works well. Why? Because it antagonizes some of the side effects of THC while enhancing some of the benefits of THC. It basically widens the therapeutic window of THC when used together. And it even decreases the appetitive effects of THC for those worried about the munchies. Again, we don't need rimonabant to help us with that. But I will mention that hasn't, this idea that CBD kind of limits the high of THC is likely the case to some extent, but it doesn't show up that clearly in all the literature. There's kind of mixed results, so I just want to paint a picture that's not black or white. This was a study that showed that administering fairly generous doses of CBD 90 minutes before smoking fairly weak cannabis cigarettes containing THC, NIDA supplied. You can see it's like 5% THC by weight. It basically didn't make people say that they were not high. It didn't work like that. I don't know, based on this study, if an oral dose of CBD administered prior to THC smoking will diminish the high. You can see really no difference in the results. What it did diminish, though, was the adverse aspects of the psychoactive effects, the anxiety and the paranoia and the uncomfortable feeling. I suspect that a lot of the euphoria and the anxiolysis and the other desirable psychoactive properties of THC are able to shine through even a very high dose of CBD administered beforehand. But when we look at the really severe adverse effects of THC, like an acute psychotic experience, CBD actually does seem to limit that. So this is from McCallum and Russo from a couple years ago, their paper on dosing, which was well done, looking at kind of the threshold for toxic psychosis of Marinol, which is just a pure THC drug, was about 18 milligrams. And it shows up pretty small here, so I can't quite see it. But if I remember correctly, a combination of approximately 1-to-1 CBD and THC, the threshold for toxic psychosis was around 50 milligrams. So half of that would be 25. So basically, in the presence of an equal quantity of CBD, the threshold for psychosis from THC went from 18 up to 25. And you can see that's widening the therapeutic index. Someone could tolerate more without experiencing this severe side effect. So these two do go very well together, and I think we have more to learn about exactly how they interact and how they work together. But this story is not just about CBD and THC. This plant is just a treasure trove of phytoconstituents that have therapeutic activities, many cannabinoids, terpenes, the acidics, and then also important to remember, as Kevin mentioned earlier, that plants figured this out a long time ago. Since they can't run away from predators, how do they defend themselves? It's with these factories. So the trichomes are on the female reproductive structures of cannabis, the structures that are going to be the most vulnerable to damage from ultraviolet and other oxidants, to pests, to molds, invaders. And so these antimicrobial and antioxidant properties that the plant is producing these compounds to achieve in the plant, they are also conveyed to people who take these as antimicrobials and antioxidants. So moving along, CBN, just some of the pharmacology, it binds to CB2 a little bit better than CB1. In both cases, it's less potent than THC, but very similar to THC. Now, CBN is not produced by the plant per se, but it's an oxidative breakdown product of THC. So especially in regions where there's a lot of humidity, and you would traditionally dry the cannabis flowers out in the sun, that ultraviolet light will convert some of the THC into CBN, and that gives the flower a bit of a different quality. Mildly sedative, according to a report in 1976. I think a lot of people in the cannabis field assume that CBN is sedating, and I think for some people it is, but what I've observed is a lot of inter-individual variability, where CBN does seem to help some people sleep, and it seems to wake some people up, and there's probably dozens of factors in there, including the oxidation of the other components that nobody's looking at, that we're not really considering. Anti-inflammatory properties and also antibiotic properties, including a potent agent against MRSA. Antibiotic resistance, not resistant to CBN and some of the other cannabinoids as well. So moving on to CBG, we have very low activity at CB1 and CB2. It does activate the TRPV and the TRPA receptors and the alpha-2 adrenergic that's the adrenoceptor, like clonidine and guanfacine. So clonidine used for treating blood pressure, but also a very valuable sympatholytic. Guanfacine, which has less of the blood pressure effects, but used more for attention deficit. So perhaps CBG will emerge as something that can help with that by suppressing excessive sympathetic activity. Do any of your patients have excessive sympathetic activity? Do any of you? inhibits a variety of receptors as well, also anti-neoplastic, antimicrobial, and antidepressant effects. And there may be some evidence that CBC in the presence of THC can actually potentiate the THC to some extent. And I have had reports that varieties that contain a little more CBC than typical seem more psychoactive. But that's not due to the CBC, that's due to enhanced THC activity. Then we have THCV, which is a CB1 antagonist at low doses, but a CB1 agonist at higher doses. Could this plant throw us any more curveballs? Hopefully, yes. But this is an interesting one. So at these low doses, this could also be an anti-munchie drug, so to speak, because of this gentle antagonism, producing weight loss, decreased body fat, decreased leptin concentrations, increased energy expenditure, at least in mice, has anticonvulsant properties, decreased edema and hyperalgesia in a mouse model, and also it lacks the adverse effect liabilities of your typical inverse agonists like rimonabant. It does not cause that dysphoria and that dysregulation of the endocannabinoid system as far as we know. Moving on to some of the acidics, THCA is non-psychoactive, but I will say that anytime there is any THCA present, there's always at least a tiny bit of THC. Some of the earlier work on THCA was very confounded because some researchers found that it's got some CB1 stimulating activity and some researchers found it didn't, and it was kind of confusing. But there's no such thing as a pure THCA standard. Even the most pure will have a small amount of THC in it. That was shown by McPartland a few years ago. But not psychoactive nevertheless, a strong inhibitor of tumor necrosis factor alpha release, which is a major inflammatory component of chronic disease, anti-cancer effects, also at least to some extent via the PPAR receptors, and it has some inhibitory activity at TRPM8, activating TRPA1 and TRPV4, and some of these other cation channels. So that's THCA. In my practice, I found it very useful for treating arthritis. It takes a little bit longer for people to respond to it because it's not an analgesic per se, it's an anti-inflammatory, but usually at the 2 or 4 week mark, people are starting to notice a difference, and I usually am recommending it via tea because there's not a lot of THCA products available, and I think cannabis tea is a really great delivery method. Moving on to CBDA. The CBDA is much more similar to CBD than THCA is to THC. If you look at the pharmacology of THCA and THC, they're very distinct. CBDA has a lot of overlap with CBD, and it seems to be more powerful. It activates the 5-HT1A serotonin receptor, but much more strongly. Does not seem to act on the CB1 or CB2 receptors. So, as we described before, in many situations, it's valuable to get that negative allosteric modulation of CB1 and CB2 in order to make people tolerate their THC better. But that's not always what we're looking for. Sometimes we want the full power of THC to shine through, yet we also want some CBD-like effects in the mix. And in my opinion, that's where CBDA comes in, because it can convey many of CBD's beneficial qualities at a much lower dose without the negative allosteric modulation of CB1 and CB2. So that's a strategy to consider. CBDA is also the only cannabinoid that's a strong COX-2 inhibitor. And again, we don't know if CBDA would share some of the liabilities and side effects of some of the other COX-2 inhibition drugs. When used at high doses, I would be cautious with some of the other problems like gastrointestinal and cardiovascular. But the beautiful thing about it is we don't need to use it in high doses. So here's a little data from 2013 in a rodent model of nausea. They're counting something called gapes because these rodents don't vomit, they just gag. And so you can count them after administering a high dose of lithium chloride, which would make most of us gag, and see what the anti-emetic activity is. And so I point out the increased efficacy of THCA compared to THC. This dosing here on the bottom, you can see it's milligrams per kilogram. So 0.05 milligrams per kilogram of THCA. A tiny, tiny dose, even for humans, especially tiny for rodents, suppressed their nausea. 10 times that dose of THCA didn't make it any better, but it really was 10 times that dose of THC that was required to even show some effect. So there was no effect of THC at 0.05. It was 0.5 of THC where you began to see the effect. So 10x the potency at least on THCA. How did these researchers know to look in these very low dosing ranges of THCA? I'm not sure. I'll tell just a quick story about THCA because I've been looking at the very low dosing range of it for a while, for about 5 years now, with great surprise still. So back in 2013, as many of you are aware, Sanjay Gupta came out with his first documentary, Weeds, and people were, looking for CBD to treat their seizures and their kids especially. And at the time, we had just started a cannabis analytic laboratory in my clinical practice. And I was very excited when a patient came in and said, I got this bottle of CBD from the dispensary and it's working. My daughter's seizures are way down. And I said, well, and I had heard that story a couple times before, but this was the first chance I had to really find out what the dosage was, because back then there was no labeling, no testing. We were the first analytic lab in our state. And so I grabbed the bottle and we took a little sample of it. We ran it through the HPLC, and I was expecting to find out how much CBD this kid was getting. The answer was 0. There was no CBD in that bottle. There was pretty much no THC in that bottle. It was a very weak glycerite of THCA. That was the only peak that was significant in there, THCA. And the kid was getting such a low dose, I had a very hard time believing that that was working for seizures. But I'm not sure about the placebo effect in cases like this. Certainly parental report can be influenced by things that the parent hopes is working. And so I didn't really know what to make out of it, except that the dispensary was selling something that wasn't what they said it was. It was some kind of a cannabis oil that didn't get people high. It must be CBD, but it was actually just a raw cannabis infusion into glycerin. Anyways, that happened a few more times, and I talked to a few people around the world that were seeing the same thing before I believed it. THCA has an efficacy range way, way down, lower than most people would expect in certain situations. Then the authors who did that last study looked at CBDA, but notice the scale is different now, micrograms per kilogram. They went even lower on CBDA, and they found that 1/2 of a microgram per kilogram, again, that is so small in rodents, it's hard to even describe. Maybe the equivalent in a human would be brushing up against a cannabis flower and letting some of that resin get on your arm and absorb through the skin. I mean, this is tiny, tiny dosing. Reduced nausea in a similar rodent nausea model. And here we just have the chart looking at COX-1 and COX-2 in comparison with indomethacin and diclofenac. And you can see the big signal on CBDA at the bottom of the graph there. Now, there has been some anticonvulsant activity reported around THCA way back in 1970, what was this? 1974, I think, 1979 it was, at very high doses in rodents. And again, as you'll learn from the rest of today, the cannabinoids are very dichotomous. They work in very high doses, they work in very low doses. There's bidirectional effects and biphasic effects. We're going to cover all of that later. But it again doesn't surprise me that we see some activity against seizures at very high doses and at extraordinarily low doses. Now let's talk about some of the pharmacokinetic properties of THC and how our bodies deal with this. And we know surprisingly little about the pharmacokinetics and the metabolism of many of the other cannabinoids, but it's likely analogous to THC, where we have the absorption, the concentration into the body fluid. We have metabolism in the liver, and I'll show you some of the metabolites in a future slide. And then we have excretion, both through the feces and through the urine, as well as through the skin and the hair. So bioavailability of THC, as you can see, it ranges quite a bit. This is an older study that summarized some of the data that was available, but oral bioavailability is pretty low regardless of what study you look at. Inhalation gets a bit higher, and then there were a couple studies of rectal bioavailability which showed that the hemisuccinate preparation was much more bioavailable than a regular suppository, and in general worked a little bit better than oral. But let's take a look at some of these curves. So on the left, and thank you for getting this up here. I appreciate it. Maybe in the future there is a way to switch this up so that it's a little bigger, because the slides appear quite small on this monitor, but you don't have to deal with it now. So looking on the left, I believe we have the oral. You guys help me out. Where are we? On the left chart, is this maybe, wow, we need some help here. How's this? Sorry, say it again? Inhaling. Okay, so, oh, right, inhaling. I can see it now. So with the inhaled cannabis, you can see the dotted line is the peak of THC, and that peaks very, very high early on. 15 minutes, we get this peak effect, and then it drops rapidly. We don't see a lot of 11-hydroxy THC. That's the larger dashed line towards the bottom, because there's not that first-pass metabolism with inhaled. But over time, what we see is the carboxy THC, which is an inactive metabolite. And I'll review those metabolites on the following slide. Now, as we go over to the right, we have a different scale on the y-axis, so I just want you to note that. Look what happens when people take THC by mouth. The blood level of THC stays way down. Do you see it way down there at the bottom? There's a decent level, not decent, I mean a slightly higher level of 11-hydroxy THC, which is an active metabolite, and then we have this large quantity of the inactive metabolite. So we have low oral bioavailability and a lot of first-pass metabolism that really ends up making very low levels of these active constituents in the blood. But what I'll say is that the blood levels of these compounds don't correlate directly with the clinical effects. And a really good example of that is when people inhale THC, their peak blood level of THC occurs at a different time than the peak psychoactive experience. When they're peaking psychoactively, their blood level has already dropped. And so you could give someone that tiny little bump of THC you see in the bottom of the middle chart there, and that might feel stronger than what you're seeing over to the left as far as a psychoactive effect. So it really doesn't correlate directly, and it's not just psychoactive. It's analgesic and anti-emetic, and all the other effects don't correlate directly with blood levels. And then on the right, I believe we are comparing. Is it intravenous, smoked, and oral? And you can see that the intravenous and smoked look quite similar. Not that intravenous is a good route for THC. It's very likely to cause psychotic transient experience. So the metabolism of THC is mainly in the liver, but there's extrahepatic metabolism as well. And you can see, just as I've mentioned a few times here, there's an 11-hydroxy form that is an active metabolite. I think people assume that it's more psychoactive. It certainly may be that way for some, but I think it's just qualitatively different. People that take cannabis more via an oral mucosal route versus swallowing it would be able to kind of describe some of the difference between having more first pass and less first pass metabolism, and usually there's a qualitative difference. Some people say the first pass, by swallowing it, they get more of a muscle relaxant effect, or maybe more of a body effect, less of a cerebral effect, and some people say the exact opposite, so I'm not sure. Now, here we have CBD pharmacokinetics, very high doses, as you can see. Unfortunately, most of our patients can't afford 6,000 milligrams, but I guess it's worth trying that in a single dose just to see how safe it is, which is ridiculous, it's that safe. But twice daily dosing, it's still very high levels for 6 days, and evaluating the effect of having it after a meal or on an empty stomach. And this was delivered via the new drug Epidiolex. And so, first of all, the adverse effects: diarrhea, nausea, headache, and somnolence. time to the maximum plasma concentration was 4 to 5 hours. It reached a steady state after approximately 2 days with very moderate accumulation. And so probably someone that's on a steady dose of CBD for even, we could say maybe 3 days, then we've reached a steady blood level. And I think that's important when we talk later about how frequently to titrate a dose. We wouldn't want to titrate it one day after the next. We want to give that much time for someone to achieve a steady level. Half-life 10 to 17 hours, no change in their labs, even with those super high doses, physical exam, vital signs, ECG or body weight, no consistent effect on sleep or sleepiness. This shows up a lot in literature. In my experience, CBD seems to help some people sleep. It seems to keep some people awake. Hard to predict who's going to be who. And no clear evidence of any drug withdrawal syndrome during the trial. So quite safe. And some of the conclusions or takeaway points: twice daily administration seems to make sense. Taken with a high-fat meal, you can get 4 to 5-fold the oral absorption. So that's probably a good idea to recommend people to take it after breakfast and after lunch is usually what I'm doing. Again, because sometimes I'm cautious about after dinner in case it keeps them awake. All adverse effects were mild or moderate, and safety data is consistent with what's currently established. We'll skip that little part on the side there. So here's some pharmacokinetics published for the first time in the last year about the acidic cannabinoids. As you can imagine, I got very excited to see this. It confirmed what I was suspecting. So the acidic cannabinoids, having that carboxylic acid group on there, they are more hydrophilic. Right? They're a little more water soluble and maybe get better distributed in the body. So let's take a look at what happened here. First, we can see a comparison of THC and CBD when taken in two forms. One is a decoction, which is like a tea except it's simmered for a prolonged period of time while covered, and the other is an oil. And you can see that these were so-called galenic preparations out of Italy. Some of the studies out of Italy are looking at the right things, but I feel like the rigor of their starting materials and procedures can be a little weak. But I'm so glad they're looking at THCA. And so you can see that there was some variability, especially in the decoction, quite a bit of variability in actually what people were taking. But nevertheless, some interesting results here. So more THC absorbed, more CBD absorbed than THC in the decoction. And then over here, when we start looking at the acidics, so that orange peak, that's THCA. If you're looking for the THC peak as far as what was absorbed, you can see it's just way, way down there. And yeah, I could do a better job explaining if I could actually see it from up here. But what I think you'll notice is that a lot greater absorption of THCA compared to THC in both the oil and the decoction. And if you look at the top of the slide, you'll see that there were roughly equal parts, right? So we're getting much better absorption. The other thing that's kind of flipped on its head in, that the study showed, and it's a little hard to see, remember the oral dosing of pharmaceutical grade THC? We saw higher levels of 11-hydroxy than we saw of the parent compound THC. That got back, that's reversed in this. So here we have higher levels of THC than the 11-hydroxy, and that's likely because the presence of these other cannabinoids, the acidic cannabinoids, is inhibiting some of that first-pass metabolism of THC, right? And that's something that happens a lot in complex botanical medicines, is that the variety of compounds which share similar structures, when they get to the liver, they have pharmacokinetic effects on the metabolism. It can really change, well, even before it gets to the liver, it can change the absorption and it can change the metabolism. And so it looks like having some of these acidic cannabinoids can decrease that conversion to 11-hydroxy. Looking over here at CBDA, again, we see some really pronounced absorption of CBDA compared to CBD. And this was just some of the data, so you can take a look at the area under the curves, and I did the math for you. And so it's looking like THCA versus THC in the decoction was absorbed 50 times better and 30 times better out of an oil, and more modest for CBD, but still much higher absorption for CBDA compared to CBD. I'm just going to wrap up here with a few more slides. I think this is a very important but controversial topic, and so I want you to just be aware of the science that we have behind it right now. A good review in the 2017 National Academies of Sciences, Engineering, and Medicine report, which looked at all the data on infants that had been, and children that had been exposed to cannabinoids perinatally and prenatally, and what they found was that the only consistent finding was smaller for gestational age. This wasn't dangerously small, this wasn't ultra low, preterm and all that stuff, but it was smaller for gestational age, which was consistent with any exposure to smoke. Basically, when someone's smoking, they're getting carbon monoxide, they're getting other chemical compounds that could interfere with blood supply and other factors in the fetus and cause a slightly smaller baby. We see it with tobacco as well. And so these authors attributed the small for gestational age to the smoke itself, not to the cannabinoids. And that's a very high-level summary from the 2017 report. There were actually just 3 new studies that came out in the last couple months looking at cannabis and pregnancy and lactation, and their basic conclusion was that all the rest of our data is really unreliable because so much of it is based on self-report. And one study came out that looked at the difference between self-report and urine toxicology screens, and as you can imagine, there's a lot of differences there for many good reasons why moms aren't self-reporting cannabis and why some are. I'm not sure, in the current political environment. Cannabinoids and lactation, they are present in breast milk. One early study from 2013 estimated that the neonate would be exposed to less than 1% of the mother's exposure, and that's per kilogram of body weight. So it is getting into the breast milk, but the exposure to the infant is very small. A subsequent study found a little bit of a higher result there, 2.5% of the maternal dose being delivered to the infant per kilogram of body weight. So unless mom's taking a lot, it's still very little exposure to the infant. But I'm not saying that so that you assume very little is irrelevant. Very, very small doses of cannabinoids can absolutely be relevant. I don't think we can say right now if this is a good thing or a bad thing because it probably depends on the situation, which is a complex family and community situation that involves factors like maternal stress and maternal sleep and some of mom's other health issues and some of the baby's issues and the baby's genetics that may relate to the mom's health issues and all sorts of factors here. What we know is that lots of kids have been exposed to cannabis during pregnancy and lactation, and they don't develop differently. Sometimes there's a little acceleration or a little deceleration of certain milestones prior to age 5, but by the time they reach age 5, it's a wash. And so this doesn't seem like it's inherently dangerous for children to be exposed to low levels. And that is the cannabinoid pharmacology talk. Thank you.